privilege and honor to be back here again this year. I think it's role reversal. We just came off the biggest drought probably in the history of human beings in California. And since I left, we've had about 4 inches of rain, and here in Dallas it's 80 degrees, so I don't know what's going on. So anyway, just to clarify, USC is University of Southern California. Most cheerleaders are not from South Carolina, just in case Dr. Blackwell has any more doubts. Okay, so how does this all tie in? We touched on a lot of topics during the lightning rounds and during the previous discussions about alternative transport, and how does this all tie in? I think the catalyst for us in Los Angeles are the so-called EMS super users. The term frequent flyers is not politically correct. We usually think about people sitting in first class who look like they don't really belong in first class. So we did a data dump like many systems have, and these are, I think, the proverbial low-hanging fruit, where these are people who have an exceedingly high use of the EMS system. So our top 20 EMS users last year accounted for over 2,100 incidents, which in our system was probably about 3,000 responses, almost 2,000 transports. So huge, consuming resources. Most of these folks are around middle age, and if you look at the last bullet on the slide here, it would make it a little easier to get these people the help they need definitively. If they only went to one hospital, but they seem to move around quite a bit. So each of these 20 top super users were transported to an average of 10 different hospitals, and the high up to 22, which really brings into the fact that this concept now of having a medical home, a home suite medical home, is really important, because some of those hospitals may not realize that this is indeed a super user and may not flag that patient to plug them in with social work or detox or something else, and they keep bouncing around the system. But believe me, every paramedic in the city, we have about almost 500 square miles, 4 million people, they know who their super users are in their neighborhoods. We did also financial analysis, because everything now is financially driven, whether you like it or not. And so we were very surprised to find that 80% of these top super users had some type of insurance, but not surprisingly, we didn't get a lot of reimbursement there. Only 10% of the transports resulted in any form of reimbursement. And if you look at the charges, and again, this is not cost, but charges, and we're a platoon 24/7 fire-based EMS system with constant staffing, so it's really hard to determine what our costs are, but almost $2.5 million of charges, and we collected about 10% of that. So this is a big financial issue. It's a big issue because these patients are truly in a revolving door and not getting the help they need. I know you probably can't see the slide from the back, but we looked at how many of these people, not just the highest number of EMS super users in terms of transports per year, but we found out a fair number of these patients actually were transported multiple times in a 24-hour period. And the dubious distinction of our top super user, probably should get some kind of prize, who was transported 180 times in the course of last year. Over almost 35 of those days, he was transported multiple times. So in the front door, sobers up, hospital kicks him out, or he leaves AMA, RMA, or just elopes, and someone calls 911, or he gets drunk again, falls down, which is the typical problem, gets transported back. So it ties up our resources, huge morale killer for our paramedics and EMTs, and again, we're not getting these patients the help that they need. So we're probably the only business in America, with few exceptions, maybe PD is probably the only one, where we don't want repeat customers. So clearly this revolving door, where these people are not getting the help that they need. Again, I mentioned this is I think the biggest morale killer for certainly my folks. They want to be available for the real calls, as they call it. And often these patients have chronic medical problems, substance abuse, alcohol abuse, homelessness. But paramedics and firefighters feel like really this is not their job, and again, when they transport these patients day in, day out, and multiple times the same shift, we're really not getting anywhere. What's going on in terms of the outside variables, and this is probably true for everybody in this room, and obviously higher impact in certain areas than others, but certainly in Southern California, we've had about 24 hospitals close over the last 10 years, so fewer ERs, increasing call load, decreased number of inpatient beds, increasing wall time, or turnaround time at the hospitals. This is becoming a real problem. And anyone who thinks that the Affordable Care Act, aka Obamacare, is going to solve that, well, I would look at the historical comparison, because when they had Romney Care in Massachusetts, they found that emergency department visits went up about 40%. Because I think what's going to happen is we clearly have a shortage of primary care physicians in this country, and those people who are already doing primary care are probably not going to view this type of government insurance as very attractive to even cover their costs, let alone earn a living. So now patients who may have held off seeing a physician for their medical problems realize I can just go to an ER without an appointment and get the help that I need. And many of these folks will get to the ER via the 911 system. So I think the Affordable Care Act is not a panacea for us, but it may make our lives busier and more difficult. We're having a tremendous problem in Los Angeles, as many jurisdictions are around the country, with the turnaround time. So the ambulance offload delays. We've started tracking this over 10 years ago. We call it wall time, when paramedics take the wall. And again, this has gotten worse as our call load has steadily increased, number of ERs has decreased, and supply and demand equation gets more out of balance. Our wall time is increasing. When we first measured this and published this data about 10 years ago, we found we were losing the equivalent of about 48 hours cumulative wall time per day, which is losing 2 ambulances. And we tried to work with our stakeholders in different hospitals around town. We transport to about 55 or 60 hospitals. And look, this is the data from 2012 to 2013. We went on about 335,000 incidents in 2012, a little bit 2% increase in 2013, which has been pretty consistent, about 2% per year. Our number of transports went up consistently, also 2% increase, a little over 200,000 transports. But you look at the third bullet down, the NAV, which is not available because there's no beds, we call it NAV beds, are on the wall, that went up 30% in 1 year. And now we're losing the equivalent of 4 ambulances per day, 100 hours per day, cumulative time, paramedics on the wall out of service. So this is becoming a huge, huge problem. And as you might imagine, the hospitals that are most impacted the most are in neighborhoods with the worst payer mix. So hospitals, and LA probably has the widest disparity in income disparity of any community in America. So my department covers Bel Air, which is, for example, the mansion where Michael Jackson died, where that cost about $25 million, that house. And we also have one of the largest homeless populations in the world, which all come to my hospital, County General. So huge income disparity, as you might imagine. Hospitals that are in the poor neighborhoods can't increase their staffing, can't increase their number of beds, can't increase the number of nurses. Consequently, our paramedics are spilling out the doors. This is a huge problem for us. This is a picture I took in my mobile data computer of my car a few days ago. Rescue 814 waiting for a bed for 2 hours. This is at my hospital. And this is not an uncommon occurrence. And some of the guys bring, they call NEV bed kits. They bring crossword puzzles, they bring their iPhones, they bring food because they're on the wall for hours at a time. Huge, huge problem. And to give you a perspective, this is not anything new. This is an LA Times article from 2002. The problem is getting worse, it's not getting better. This is finally getting attention of the politicians and the media, which hopefully will help. And we have discussions with the hospital executives, CEOs, and everything else. But what we found was hospitals where they look at the patients as paying customers because they have good insurance and they're well off and in a good socioeconomic area, they look at every ambulance that's lost due to diversion of paramedics on the wall, they look at lost potential revenue, and in neighborhoods where the socioeconomic conditions are not favorable, they don't want any more business. So this is a real problem for EMS. ED volume in California hospitals over the last 5 years grew by about 20%, but what's interesting, you look at this next graph, the predominant increase in that was almost exclusively due to patients that were not admitted. The number of admits, which is the bottom line in red, really leveled off and started trending down in the last couple of years, whereas the ED patients that did not require admission, which were lower acuity, consequently, actually went up considerably. So where does ACA fit in? As Dr. Pepe alluded to a moment ago, hospitals will no longer be able to be reimbursed for readmissions within 30 days. So now there's a financial incentive by the hospitals to work with the provider agencies, fire departments, EMS agencies, ambulance companies to say, maybe I'll pay you up front, prorated or capitated fee schedule to go on our patients who belong to our accountable care organization, or ACO, and keep them out of the ER, do preventive care or transport to an alternative destination. Obviously, this requires an approach with multiple stakeholders, particularly when you're dealing with the super users, most of whom have some type of insurance. Many people here and many of the Eagles already have systems where they're gaining experience with community practice paramedics, doing some proactive preventive care, but what about mid-levels in the field? Right? Because paramedics now, I believe, have really taken the place of doctors making house calls, which they did when I was a kid in the 1970s. Paramedics are trained to resuscitate, stabilize, and transport. When you go on a patient who has chronic medical problems, social needs, substance abuse issues, Is that really what you're trained to do, or is there someone better served to deal with and mitigate those problems? So is there a role for mid-level providers in the field? So we're trying to put together a program now that's patterned after a program they have in Mesa, Arizona, where they actually marry up a nurse practitioner with a paramedic in the field. They call it a transitional response vehicle. The NP is hired by the hospital, and the issue is not alternative transport. The issue really is the treat and release versus treat and refer. The literature is no surprise here. This is an article from JAMA from last year looking at a large percentage of patients that we transport who have Medicare, which tend to be older or chronically disabled. Up to a third of those could be transported to an alternate destination. But the issue is if you go ahead and put someone like a nurse practitioner in the field, they could perhaps, not just in dispatch, but on scene, treat, refer, treat and release with autonomy, write prescriptions, refill meds, and free up paramedics for the truly time-critical ALS-type cares. So we're undergoing a paradigm shift in EMS, whether we like it or not. I'm still amazed that many EMS systems now are still all ALS, have no tiered dispatch, and run lights and sirens are hot on every call. But it's clear, if you look at your data, most of our calls are not time critical. It's like having a trauma team come down, someone with a scrape on their knee. It just doesn't make sense. How responsive is your agency to change? I'm in a big city fire department, which is based on tradition. You know, we pride ourselves on 120 years of tradition unimpeded by progress, but even now we're being forced to change. Some of that is economic, some of that is political, but we have to change. So to summarize, EMS recidivism, our frequent flyers, our super users, account for a disproportionate EMS responses. I applaud those agencies that are already well on the way to try to get these people the help they need and free up their resources. The Affordable Care Act, I think, will provide a nice incentive and catalyst to try to get these people help and free up our resources for the truly time-critical calls where life is on the line. And I think you must partner, not just as medical directors, but operational chiefs and so forth, and the frontline providers such as paramedics and EMTs with multiple stakeholders to get the most appropriate resource to the patient, not just necessarily a fire engine and a paramedic ambulance. Thank you very much.